Hi, my name is Thelma Browne-Kaine, and this is my presentation on my DNP project. My topic was the efficacy of the Geriatric Depression Scale 15 in the identification and management of major depression in older adults in primary care. Committee members: Dr. Stegman, DNP Chair; Dr. Stegman, Nurse 705, Professor; Committee Person, Dr. Fawali. Introduction. Major depression is a growing public health issue that poses elevated mobility and mortality risks. Older adults are overly affected by major depression due to challenges in accessing healthcare, diseases, loss of loved ones, and adverse life events. Due to atypical presentation, older adults with depression are likely to be misdiagnosed or underdiagnosed. This risk increases the likelihood of inappropriate treatment and adverse treatment outcome. This proposed Doctor of Nursing project is the implementation of the 15-item geriatric depression scale in diagnosing and managing of major depression in adults in a primary care setting. This scale is a peer-reviewed scale and is a validated scale. The GDF-15 scale can help promote diagnosis and management of depression in older adults. Background. The current aging population trend increases concerns and concerted efforts for early identification and treatment of major depression. The Geriatric Depression Scale screening tool improves patient outcome by enabling early diagnosis of major depression. The GDF-15 increases the identification of adults with major depression by 100% and lowers the risk for missed cases to 36%. The GDF-15 is effective and validated in identifying depression. It helps reduce caregiver burden costs. Significance. To strengthen the detection and management of depression, assess the impact of education, gender, ethnicity, and age on the GDS-15 measures. It lowers missed cases by 50% in 8 weeks, increase recovery by 50% in 8 weeks, improve the quality of life by 50% in 8 weeks. Review of literature and the search history. The Medline databases provides access to healthcare and allied sciences literature. Keywords and phrases were used. I also used the Cochrane Library, I did Google Scholar, and also PubMed. Key phrases were used, and such phrases filter was limited to articles. And using the search filter between 2019 and 2023 and in English, using the same entry with 15-item geriatric depression scale instead of the GDS-15 narrowed the results to 390 articles in 0.7 seconds. In PubMed, only one article was found. And I also used older adults, and I also use and all to narrow my search. Integrated literature review. The integrated literature review assessed the current literature on the efficacy of the Geriatric Depression Scale 15 in evaluating major depressive symptoms in older adults. It covered key terms including the skills reliability of complication and depression, differentiating between major depression and related complication, and assessing the severity of depression. And the theoretical framework that I use the NOLA Panda health promotion model, which defines health as a dynamic positive of an individual. The model focuses on promoting patients' wellness through interaction with their immediate surroundings. Panda also emphasized the uniqueness of patients' characteristics in influencing their behaviors, which then affect their health and related outcome. The key component of this theory is the perspective that nursing action can modify these variations to improve health and enhance functional ability and quality of life. Methods. Depression is one of the most common mood disorders that is highly prevalent among older adults. Globally, the prevalence is rated between 10 to 20%. Methodology. This was a retrospective Doctor of Nursing practice scholarly project. It was conducted in an outpatient general practice clinic. At this clinic, they see about 30 to 60 patients a day and over 6,000 patients annually, and for which 75% of those patients are geriatrics. For the design, the study used a retrospective research design. And the answers are based on the feelings experienced in the last week and are in the form of yes or no. The outcome collected were entered into a data tracking tool in Excel. And these data were collected from existing patient charts. For the inclusion criteria, adult patients who are 60 to 90 years of age must be willing to participate in the exercise voluntarily, diagnosed or suspected of having major depression, living in the community neighboring the facility for the next year, enroll as patient in the clinic. For the exclusion criteria, individual 90 or older, individual 59 years or younger, cognitive impaired, those undergoing medication that is likely to influence their emotional states, patients diagnosed with other psychiatric illnesses, patients who have alcohol or drug dependence problems, individuals 90 years or older, individuals that are 59 and younger, individuals who are diagnosed with complex mental disorder, and staff members in that facility were part of the exclusion criteria. For a sample, I used descriptive statistics, which analyze and describe a data set characteristics and features. The data were collected from adult patients seen at the clinic from July to November, and the sample size was 33. Following the initial assessment, the patient underwent interventions, including medication. Some got on the therapy, some we did suicide assessment, some did combined assessment while being monitored for changes in depression rates. For the data analysis, I used the Wilcoxon test, non-parametric statistics test, which compares two dependent groups. And this is sensitive to data characteristics. The study sample was 33 participants, and 25% of those were African Americans, 50% were African immigrants, and I also use pie charts and histogram to enable the comparison of the changes over time. This is the data analysis demographic data. Like I said, the subjects were 33 older adult patients, aged 60 to 89 years old, ethnicity. 50% of the 33 patients charts that were reviewed were African immigrants, 25% were African Americans, and 25% were other ethnic groups. Data analysis demographic. The gender were 57.6% were females and 42.4% were male. And this is the graph for the ethnic distribution of the participant in the project. And for this graph, this is the gender distribution, and you see how the female were 57.6% and the male were 42.4%. For the results, we did a anomaly test for July, August, and November. Depression prevalence data. In July, it was between the initial visit in July, where SD 9.5, which is SD 4.2, based on the GDS-15 scale. After the screening, the average depression prevalence for the patient declined to the margin of 37.7 to 5.9, which is SD 3.0 in August. And by the end of November, that number decreased. This is table 2, the descriptive statistics on depression prevalence for July, August, and November. So as you can see, 9.5 in July, August 5.9, and in November it was 3.1. So they rank depression prevalence pre-diagnosis in July and post-diagnosis in August and November also decreased. The pre and post-diagnosis and treatment of depression for July, August, and November. July through August was 4.79, November through July 4.36, and then November through August, November and August 2.91. So it showed the significant value of less than 0.001, less than 0.001, and in November 0.004. And this was the histogram for July on the GDS scores. So in July, the GDS scores were high, and in August, the GDS scores were also still high, but not as high as the GDS scores in July. And this is the November GDS 15 score. And you see how it went down significantly to 3.9 in November. The strength of this project was the strength is effective, the tool is effective and evidence-based decision-making tool, and using primary data gives research higher originality. Existing research on the significance of regular screening and management of geriatric depression. The aspect impacted the study positively, demonstrated their validity, and on the topic area. The significance is validative and reliability of the two. For limitation, the lack of randomization affected the study's broadness. Random sample selection enhances sample representativeness to the target population by ensuring all members have equal opportunity to participate. The study used a convenient sample of patients available in the EHR records. The sampling method exposes the study to biases, which lowers the overall validity and reliability of the findings. Discussion. The finding of the study indicated the significance of the GDS-15 scale in facilitating the accurate diagnosis of major depression and enabling effective management. The effectiveness is indicated by the continued improvement of the participant depression levels from 9.5 points in July, which indicated high depression levels, and then in August it was 5.9, which indicated moderate level, and by November it was 3.9 points, which indicated low levels of depression. Implication for practice. The use of evidence-based assessment tools to guide thorough evaluation and enable accurate diagnosis. Consistent use of this tool in this population show declined levels of depression with treatment. GDS is aligned with the DSM-5 manual, which is the gold standard diagnostic manual for mental disorder. Observing patient changes allows the modifying the treatment plan to achieve the main objective of the GDS-15, which is identifying and managing major depression in older adults. For recommendation, the GDS-15 is reliable and effective tool in detecting and diagnosing geriatric depression to facilitate timely and effective management of major depression. The study shows statistical significance between the pre and the post implementation of the GDS-15. The GDS-15 mean score for July was 9.53, which improved to 5.94 in August and then 3.75 in November, demonstrating a progressive reduction in severity of depression. And this study also showed that combined therapy are more effective. So if you combine therapy and medication to treat major depression in older adult patients, it's more effective than using just therapy or medication to treat major depression in older adult. And at the end of this intervention, it was indicated that major depression decreased in that population. Plan for sustainability. The plan for sustainability is cementing change in most critical part of the transformation process. It pushes stakeholders from the status quo to a higher stability with higher organizational outcome. This outcome is achieved through comprehensive staff education. Staff education prepares the staff to overcome barriers in the change process. This education will keep the staff motivated. Regular stakeholder meetings and consultation will help track progress over time. And adapting a culture of efficiency bolster productivity, safety, optimization, and effectiveness in healthcare organization. Plan for dissemination. The approach will entail a detailed presentation on the objective, the findings, the recommendation to nurses, physicians, and psychiatric practitioners. Also doing like journal entry and, putting it on the organization website and putting it on social media, making memos, making posters, helping family members to be able to access this document on the website will enable the organization to disseminate the information for this project. Thank you.